Welcome to episode 48 of the Headspace and Timing podcast, a show dedicated to changing the way that you think about veteran mental health, brought to you by the Change Your POV podcast network. On this episode, we have a conversation with Dr. Ted Bonar, a clinical mental health professional that's dedicated his practice to serving veterans. Dr. Bonar and I have a lot of good conversations, but most importantly, we talk about the need for mental health professionals to get the right training if they want to work with veterans.
Over the last couple of years, these trainings have gone online, right, rather than in-person trainings. And it's a webinar, or and some of them are really, really good, right? But is it competent? Is it immersive? Is it culturally appropriate? Can you ask questions? Can you get in there and talking about why somebody drove the way they did in a combat zone, and why learning to drive down University Boulevard is hard, and that's not necessarily PTSD? And if it is, we got to know how to treat PTSD. And if it's not, we have to know how to treat it as reintegration, right? That conversation, I am really worried that conversation is getting lost because, training mental health professionals in veterans work is no longer the hot thing.
Welcome to the Change Your POV podcast network. You're listening to Headspace and Timing, a show dedicated to breaking down the stereotypes about veteran mental health. My name's Dwayne France, and I'm a combat veteran of both Iraq and Afghanistan. After I retired from the Army, I took on a new mission as a clinical mental health counselor for my fellow service members. If you served in any branch of the military, you're familiar with the M2 machine gun, the 50 cal. It's one of the most effective weapons in the military's arsenal. If the weapon's headspace and timing wasn't set right, however, it was just a huge useless chunk of metal. Veterans can be rendered inoperable if their headspace and timing isn't set correctly either. That's my goal with this show, to change the way that we think and talk about veteran mental health and reduce the stigma against seeking support. Each week, we'll talk with mental health professionals, veterans, and those who support veterans, service members, and their families. We're going to have real and honest conversations about a topic that most just don't like to talk about, veteran mental health. Let's jump into this week's conversation. Hey folks, welcome back to the Headspace and Timing podcast once again, and as always, we really appreciate you taking the time to listen to the show and to learn more about veteran mental health. Whether you're a veteran, a family member of a veteran, or a provider that's working with veterans, we definitely appreciate you taking the time to understand more about what's going on. A lot of times we have some providers on here, some mental health professionals. We've had our share of those who have been in the service, like myself, and then those who haven't been in the service, like my guest today, but have taken the time to learn and understand and really get to the bottom of how to kind of bridge that gap. So I would like to introduce my guest today, Dr. Ted Bonar. Ted, hello.
Hi there.
So thanks for coming on the show. And before we really get started, kind of the stuff we're talking about, I'd like you to introduce yourself to the audience and talk a little bit about kind of what you do and what you've done.
Okay. Well, let's see. And my guess is you want me to focus on why I'm interested in this field and kind of how I got involved in it.
Yeah.
Okay. I'm a clinical psychologist. I'm based in Columbus, Ohio. Moved around a little bit. I'm actually a second career psychologist. Meaning I had a whole first career. I was a musician for a long time, and way back about 4,000 years ago, I got a bachelor's of music degree. I was a drummer, lifelong drummer, and spent my 20s playing drums and playing in bands and recording and working at record labels. And then so a very different life than what I live now, and very different than a lot of the things that we're going to talk about today, is my guess. I hit my early 30s and There were many different things that came into my life that it became clear that, I wanted to make a change. And that's when I entered graduate school and went into psychology. I did not have any clue that I wanted to work with veterans, military or veterans. It wasn't in my world, right? Like we see it today with a minority of our population serving, an all volunteer force, and 1%, or I should know the statistic.
Right, but fractions of, but it's whether it's a 1% or less, yeah.
Exactly, like 1% or less of our population has any connection to the military or direct connection to the military, and I was, I'm one of the 99% that had. It just wasn't in my world. I mean, I might have been aware of world events, but nothing else. And this was back, kind of before a lot of the. I think that we're doing a better job over the last 5 or so years about being aware of the military, or I should say civilians, like non-military folks like myself. Our society, our culture, being aware of military and veterans over the last 5, maybe a little bit more than that, years. We're doing a better job. But back in the early 2000s, like nobody was talking about anything unless you were a military family or unless you've served. And I was one of the people that just wasn't paying attention to that and didn't know much. I'm in graduate school and I'm in training, right? And I got a placement at the VA in Chicago. And I got that placement. This is in 2005. So we were just starting to see some Afghanistan folks come through the VA, but primarily it was still Vietnam vets and Gulf War vets. And I ended up on that placement, and I wanted that placement because it was a really good site with a great reputation for training. I did not apply to that site because I wanted to work with veterans. I didn't know. I just wanted to be a good, learn how to be a good psychologist. I'll cut to the chase. By the end of that year, it's a year-long training commitment. By the end of that year, I knew I had found what I wanted to do. It had changed my life. It had been it had a profound impact on me. I loved everything. I got a chill up and down my spine talking about it now. It was such an important, profound moment for me, and I just it became part of everything I wanted to do moving forward as a psychologist. I looked for opportunities to work with veterans in military, opportunities for training, opportunities to learn. I sought it out on future training sites, and I've already been making this kind of a long story, and I could make it a longer one. So maybe we'll get into some of those other things. But that was the beginning of it, of me becoming a psychologist wanting to work with military and veterans. And since then, it's just been one step after another, and I've been involved with some specific organizations that did a lot of work. I am now an independent. I have a private practice, and I am now a person that goes out and does trainings about how to work with military and training other mental health providers, psychologists, social workers, counselors, and I've done a lot of that work. And I believe in it so deeply. I think that there is still such a divide between civilians and military, and I want to close the gap. It's not up to me to close it entirely, and I can't, but that's certainly where I want my efforts to be focused. So I don't know if I got off on a tangent there.
No, that was I think that was great, and it's really interesting that you came in without any connection. Others maybe have had family or uncles or fathers or something like that, but you came into working with veterans, maybe not knowing much more than just what you saw in like Platoon and Black Hawk, movies and stuff like that, right? So what about that year was so impactful for you that made this that it was just an opportunity, but it turned into a calling? It sounded like.
Yeah, it really did. And I apologize about my dog barking in the background. I don't know if that's disruptive. It did become a calling, and you have to remember this. So this was only my second year of doing any clinical work. So I was green, right, young, and didn't have. I mean, this is the second of 5 or 6 years of clinical training that I was going to get. And I was already all in as a psychologist in training. I knew that was right, and that this is what I wanted to do, be a psychologist and be a therapist. What I ran into at the VA was, there's some exceptions to this, but by and large, individuals who so deeply wanted to be better, they wanted to get help, they took it seriously, they were earnest, they were dedicated, they were passionate. And it moved me again and again and again. It was like, you go in as a therapist, you close the door. I'm going to stereotype and say some stuff about just general clients. I mean, you can, close the door. I've done a lot of university counseling centers, so I've worked at universities quite a bit. And so I'm going to be a little bit unfair to that work, because that work is
very different.
It's very different. It's also very important, and there's really good work that gets done there. But it can be true that you can go behind the closed door with a student in college, in a university, and they're talking about their roommate who stole their cheese out of the refrigerator, right? And this is the work, right? Now, I'm being a little unfair because that work in university counseling centers is just as complex as any work that I've done anywhere. But that is one subset of that work, right? Like, which roommate stole the cheese and how do I manage that? Well, at the VA, that's really not what's happening, right? At the VA, everybody that I worked with, every veteran, and I was working with veterans from World War II up to a 19-year-old that just came back again. In 2005, very few veterans.
Just started.
Just started. But it was there. But every other era, back to an 85-year-old man that, from World War II, and some guys that were on the Indianapolis, just some astounding stories of, where these guys came from. And just every one of them was powerful and moving and profound and earnest. Now, the subsection of that is the exception to what I'm talking about at the VA is there was absolutely a subsection of people that had memorized their list of symptoms and were talking about service connection and what are my benefits and how is this treatment going to affect my benefits and that kind of stuff. And so that was there, and that it's still there. Yeah, absolutely it is. But it's not the majority. And even of that subset, that says something about the kind of work that you can do with that person also. So the depth of the work was so profound to me, I just couldn't get away from it, right? I just wanted it. And so I guess that's kind of selfish, right? That it moved me as a therapist to do something, right? To be better, that it satisfied something in me that I wanted to do. I didn't want to just punch a clock. I wanted to help somebody. Everybody I came into contact with, they wanted help. They said it in different ways and they had different needs, but it was just that powerful. So does that?
Yeah, and I think that and knowing my experience both as a combat veteran and as a therapist is these are things that you hear that are outside the normal realm of what we would experience just in a U.S. community. And so you coming in not having any deep understanding would hear things that in many ways are shocking. And they're not shocking to combat veterans. An example that I can freely give is one of my co-hosts, Eddie Lazary, on one of his shows, we were talking about a point in which he was instructed to go out into theater. A colleague of his had just hit an IED, and his platoon sergeant came up to him, and right before he went out, and he said, "Lazary, make sure you find his legs." Like, that's not a phrase that you would hear at Kmart. Right, that's not something that you would hear in your normal day-to-day, But for veterans, that is both commonplace and just one click on the wheel of just hundreds and hundreds of things that are outside the realm of normal human or normal American existence, let's say. And so for you, that's the kind of stuff that you would hear. I think that would be different from Who Stole My Cheese. It's these very amazing. I mean, I've veterans that were, like you said, at the turning point of history with some really, really significant but also amazing things.
Yeah. I think you're right, but I learned how to hear that stuff.
Right.
And I learned it over time. Like I think I was a perfectly fine practicum student that year. But sure, I had to work through what it was like to hear that stuff, right? There was a learning curve for me. But, I think any mental health professional, if they're being honest, I don't know that ever ends, right? Sure. Like, I'm going to keep hearing stories. Now, I'm better at hearing somebody's story and experience. I have heard more. I don't get shocked as often. But having a human experience as a therapist, there's value in that, right? And in my experience at the VA or working with, even if it was early on or now, somebody can tell a story like that, or something horrific or an atrocity, or anything along those lines, and I'm allowed to have a reaction. Right. Sure. And it actually, that's part of what it took me some time to learn as well. How can I have a reaction without it seeming like I don't understand anything about what you're talking about? Right. So there was a learning curve for me there. At the same time, there were people talking about, we're veterans. And I've also worked with active duty military, who want to talk about their life having nothing to do with the military.
Exactly, yes.
And that was, I think, also something important, and I think it remains important, and it can be tricky to talk about, because I've had people just say, look, I don't want to talk about any of that stuff. That's not what I'm here for. I'm not worried about it.
Right.
And meanwhile, like a mental health provider, like a civilian mental health provider like myself, like I've had all this training. Well, let me screen for PTSD. Let me screen for this and that. And they're like, I can't talk to my wife, right? Or I can't get out of bed because I'm because I'm depressed or something. I'm just making stuff up now. But they have nothing to do with their military service. I think that I've gone in and out of a couple of different settings, right? Like I was in the VA, and that was VA stuff, veteran stuff. I then went into University Counseling Center work, working as the veteran specialist. I did a lot of other stuff there that we may or may not touch on. But in that case, that's where I met a lot of people. They were like, yeah, well, I was in the military and I did deploy, but now I'm here and I got to talk about this other thing, right?
Mm-hmm.
So,
right.
and how do we integrate that stuff? And it's not all, we as mental health providers, I'll use the collective we that'll include me, can be challenged not to put a veteran in the veteran only category. Like, oh yeah, veterans are people too, right?
Right.
Oh, veterans are human beings that have lives, also outside of their military service. Okay, so when do you ask about stuff? When do you not ask about stuff? So I think that's been part of my journey as well, is to try to listen at that level.
And I think that's very important, and it's great that you brought that up. I've experienced that myself, in which and I was talking to a psychologist and asked how many deployments, and I've had 5 deployments, and she said, well, of course you have PTSD. Like, no symptoms, no nothing. And I had to back off. And I'm like, well, actually, 3 of those deployments were nothing, right? They were, right, sleeping on a cot for a year. So let's not, but let's not jump to that conclusion. Let's not automatically go to the place. And that sometimes can perpetuate the stereotype of all veterans, that sort of, absolute of all veterans have PTSD, or, all veterans must feel ashamed about their service or whatever. And so if you're starting from a place where you think you already know the solution or already know the problem, then you're going to take your skills and apply the solution when it may be misplaced.
Yeah, I've really, that's something I'm so passionate about, and I try to address that and talk about that in different ways. I've run into people. I'm going to use some bad examples. I don't think that this is the bulk of the mental health profession, but it's clearly there. I've had mental health professionals, be adamant and passionate that deployment in and of itself is a trauma, or can be. And I'm like, no, right? Like, well, we might have to talk about that a little bit. Like, that's an assumption that we make that then stigmatizes veterans further.
So it would be as if the mental health provider without any military experience would say, well, that would be traumatic for me because I wouldn't be used to that, being away from my family and sleeping, in whatever the images are. I'm sleeping on the ground for a year in this hut in some faraway country. That would be traumatic for me, so therefore it must be traumatic for everyone. That's a little bit of a universality.
Well, yeah, I mean, that's one version of it. Another version of it is this much deeper experience where I've heard people talk about, like, well, the only reason somebody would enter the military is through this societal manipulation, that's the only way they can get out of something. And that's right. They dig into all of this deep socio-cultural stuff, and saying that is like a cultural trauma that drove somebody. And it's like,
I was just tired of, I didn't want to sleep in my dad's basement anymore. That was it. I was tired of working at pizza places, and that was it.
And that's right. It's like, we've already lost talking to the person before we've even met the person. Right. So that's like one end of the spectrum. I don't run into that too often, but it's out there. The other end of the spectrum is more along the lines of what you were saying before. Like, if you've deployed, you must have experienced trauma. You must have PTSD. Or if you are a woman, then you must have been sexually assaulted and therefore have PTSD, which is also a vastly untrue statement. Now, somebody might have experienced a traumatic event, but even if somebody's experienced a traumatic event, or even a series of them, that does not mean they have PTSD. Somebody may have been sexually assaulted, and that doesn't mean somebody has PTSD. Now, those are complex details that have to be worked out and talked to with a human being, right?
Right.
The actual veteran you're talking to. And those are, you have to learn how to ask the questions. But if you have those as assumptions, mental health professionals are starting from, I think, are not starting from a great place as to how to have a connection with a veteran, right? Does that make sense?
No, it does. Absolutely. And so for you as a civilian and as someone that you were in the mental health field and you approached veteran status, Whereas I came at it from the other side. I came at it from, I was a veteran and emerged into the mental health field. And so in different ways we can be, variously effective. But for you, how was it for you trying to learn the culture as you were, you're building the plane as you were flying it, so to speak, as trying to get over that, that hesitation from veterans, especially at the point where you went into the VA. These veterans they had seen it all, heard it all, 10, 15 years, 25 years, probably some of them were just, they were so jaded. How was it for you to get into that?
Excuse me. It's a great question. I don't get the question as often as I used to. I have more confidence now. I have more training now. It might also be because I'm not working in the VA. When I was in the VA, I'd get that question virtually every time I met somebody. Or what do you know about what I went through? Or how do what do you know? What I've come to believe, and I had far more training about military culture after working at the VA than while I was at the VA. The VA was immersive, right? I just was in it.
Right.
I had supervision, and I had my experience of going 1 hour into the next hour, into the next hour, into the next hour. And so some of it I learned by attrition kind of thing. But I had much more specific training after. Either way, whether it's at the VA or now, I still think I have the same approach. Diversity matters. Diversity of experience is in every single session I have with anybody. Whether it's based on race or gender or sex or religion or politics or socioeconomic status or age or neighborhood or country of origin, you name it. Something is in there that you don't understand what I've been through. You don't understand where I come from. You don't understand how I see the world. You don't understand what informs me. You don't understand why I'm asking for help. You couldn't possibly help me. What do you know about where I've been? Every single person that I could work with could say those exact same things. It's my responsibility to be able to respond with dignity, with respect, with curiosity, with acknowledgement that I don't know it. If I go into any session with a veteran thinking I know the lingo, and I start talking with slang or acronyms the way you do, you're going to spot it from me a mile away. You're going to spot it the first time I say something that I don't really know. So, I lean back on authenticity. I'm no expert, right? Now, I'm an expert in some things, right? I'm an expert in treatment of PTSD. I'm an expert in treatment of suicide. I'm an expert in working with somebody with depression. Right? That's the mental health field. I'm not an expert in guns. I'm not, right? I'm not an expert in the military. I know a lot about the military. I think I'm culturally competent about how to work with somebody with a military history in the context of mental health and treatment. But I can't hold myself up there as something I'm not, right? I can go give a lecture on military culture, but me giving that lecture on military culture is, how do I understand that person as a mental health professional? How do I know the right questions to ask, right? I think what I'm trying to do is kind of talk a little bit about my overall approach, that I'm going to shy away from saying, oh, no, I do understand exactly what you've been through. Well, you know what? How could I?
Right.
Right? I wasn't in Vietnam, right? I was born in 1968. So, all right, does that mean that I can't help a Vietnam veteran? I hope the answer is no. I hope the answer is no, it doesn't mean I can't. I hope it means I can. If the answer is I can't, then the only people that we're going to have treating Vietnam veterans are other Vietnam veterans. And I think that stigmatizes veterans more than if I learn enough to be able to help a Vietnam veteran. Extending that to somebody who's 25 who just came back from somewhere, you know, the DMZ, right? Who just came back from a deployment that was not in a combat zone. Somebody who just came back from something you can't talk about. Somebody that never got out of Kansas, right? I have to be able, you know, if the only people that can help those folks are the people that shared the exact same experiences, we don't have enough mental health providers.
Right. And we don't in the nation anyway. I mean, that's number one. But one of the, or the primary reason why I came in, obviously where my interest was, that there was acknowledged not to be enough even combat veterans in the mental health counseling field in general, but much less likely that it's an OIF or OEF veteran like myself, you know, that there simply aren't enough of us. I recognize that there are not enough a combat veteran with no mental health professional experience in the military that come out and gain that. So you're right. There's no way that we could provide enough. But then again, and that's what this show is about and the blog is about, is trying to help others who want to learn, like you obviously had that desire to learn more, to help the most that you could for the clients that were in front of you, to help those that are interested become that, what you were talking about, culturally competent, that I can maybe talk about things, or I can explain things in a certain way as a mental health professional to other mental health professionals, that they could then understand that. And that sounds like sort of where you got to later in your career, where you had developed a level of competency and then turned around and passed it on to other providers.
Yeah. Well, I absolutely, that was, I mean, that's really that became my path. I was in university counseling work for a couple of years, and this was in 2007, 8, 9, 10-ish, 6, 7, 8, 9, 10, something like that. And even then, okay, so OEF, OIF had been happening for a while, but there still wasn't like this overwhelming movement towards how do we help veterans. It was still like, well, the VA is there, send them to the VA. Mm-hmm. Right. You're
talking about in DOD. DOD was pretty much like that's the VA's problem. We broke them, they fixed them.
That's right. Well, not only the DOD, yes, the DOD, but everywhere else. Universities did not have it together. Community mental health centers did not have it together. Private practitioners did not have it together as far as being ready to work with veterans that were coming home. And it was around 2007, 8, where it's like, oh, all these guys are coming back, and now we gotta. So VSOs started springing up, and I ended up working with an organization. I hooked up with Center for Deployment Psychology, and a lot of people know about that organization. We were really one of the first, and I was on faculty, on staff as of about 09 or 10 as one of their subject matter experts, and involved in creating the curriculum and teaching the curriculum how to work with military and veterans to mental health providers. As a civilian, I was primarily teaching other civilian providers. I did do some training for DoD providers because we were involved with MTF providers in psychology internships and in staff at MTFs. So I was with them for 4 or 5 years, and I was on the road training mental health professionals about how to work with, whether it's transition, reintegration, culture, depression, suicide, PTSD, sexual assault, women in the military, that kind of stuff. I was doing that and that's really where, when my career was like, I've got it. Like, this is what I want to be doing. That was the drive for me. And that's when I met a lot of, so many different providers around the country, some of which were fantastic and knew so much and were so ready. Others were starting from scratch. Like, what's the military? And, entering the military on its own is traumatic. Like, well, what, that person is still there asking me for help. So I want to help that person say, well, actually, let's talk about that a little bit, right? How do we get past that to a different place? So that's kind of where my road ended up going.
So, and that's really interesting. I'm glad that you brought that up, Ted, because I see, when I see in my community or around the nation where somebody's trying to say this is, I'm teaching military cultural competence to providers, they always start off with the basics, with the assumption that a provider doesn't have any understanding. So, like, let me explain to you what HUA means, and these are what the stripes mean, and like, it's always a very basic level where you had some providers like, look, I got all that. I need to get into the nuances of the paradox of them, having emotions in one theater that were effective, but now they're home and they're not effective. So you saw providers that were at different levels, and it's really good that you were able to modify. You're able to speak at the basics, but those that needed advanced understanding, that you were able to do that too. I'm not seeing that in a lot of trainings.
Yeah, that was really that was kind of our mission, because we had to train and teach to the full spectrum, right? I remember vividly, and I would still use it if I was doing those specific trainings. I would put some basic acronyms up on a PowerPoint slide, and I'd get to OEF, OIF, and before I had like what it stood for, I'd ask the question, how many people in the room, is to 50, 60, or 100 people, how many people in the room know what OEF and OIF stand for? And maybe 5% of a room of civilian providers would say they knew what OEF or OIF was. And, right, okay, well, this is a person that is starting from scratch, right? And, like, you don't have to know the 7,000 acronyms, but you need to know OEF, OIF. If you learn nothing else coming out of today's training, know what this is, right? We had to teach to that person, because that person may work with a veteran. And if the veteran is like, who's this, guy? I want to prevent that. I want to prevent the veteran walking out with having no faith in mental health providers, right? And at the same time, we had to amp up and have really nuanced, sophisticated training in evidence-based treatment of PTSD and suicide, because it's not being done enough. And all of these things that we're talking about are huge barriers to care for military and veterans to believe that mental health providers can help them. And mental health providers, I think we must demand that mental health providers do a better job at speaking the language, so that they don't send a veteran off saying, what does this guy know?
Right, and even that is a level of awareness that it needs to be on the mental health provider's part, is that the amount of, whatever you want to call it, intestinal fortitude, courage, I'm just fed up with this, the amount of effort that it took for that veteran to come into that room.
Yeah.
And then if they go up against, like, if they knock on the door and there's no answer, or they knock on the door and it's somebody who isn't effective, it's likely they're not going to re-engage.
Yeah.
And I often say a veteran doesn't need a reason to avoid mental health treatment, and a bad mental health provider can essentially, and I've seen it, as you said, and this isn't universal, but I've seen it where they go away 2 or 3, 4 years later. Now they come back when life has crushed them again and say, okay, maybe I'll give this a shot. But that negative experience could keep that veteran from years of wellness that just some basic understanding could have prevented.
I totally agree. And it's actually one of my real worries right now. Training mental health providers was hot between 2010 and 2015. And in my experience, it's not hot right now over the last couple of years. Training mental health providers was this thing where a lot of money went into it, and DOD did this, and then we had some contractors like CDP, which is where I was, and some other people were doing it. And And I would lay out the argument that you just laid out perfectly, right? And I did a lot of work with universities and university counseling centers because at the time before 2009 and 10, universities, like a lot of people, just say, oh, well, go to the VA, like we were talking about before. Well, wait a minute. At a university, a veteran at a university coming home, paying their student health fee, has as much right and access to care at the on-campus counseling center as going 75 miles away to the VA. And it's convenient and they paid for it and they should get their sessions. And if that's true, then the people in that counseling center better be ready so that the veteran doesn't turn around and walk out because, nobody knows anything. So a lot of attention was paid to trying to bridge that gap. Over the last couple of years, these trainings have gone online, right, rather than in-person trainings. And it's a webinar and some of them are really, really good, right? But is it competent? Is it immersive? Is it culturally appropriate? Can you ask questions? Can you get in there and talking about why somebody drove the way they did in a combat zone and why learning to drive down University Boulevard is hard and that's not necessarily PTSD? And if it is, we got to know how to treat PTSD. And if it's not, we have to know how to treat it as reintegration, right? That conversation, I am really worried that conversation is getting lost because, training mental health professionals in veterans work is no longer the hot thing. It's not that it doesn't exist, but it's not the hot thing anymore, right? There are other hot things out there that are getting, and there are other things that are worthy, right? Honestly, there's a great movement towards, I can think of two of them, right? Suicide prevention, good. I'm never going to say that's not important. And diversity. And I'm never going to say diversity isn't important. It absolutely is. But what that means is there's only so many dollars to go around. And the training for veteran-specific cultural competency or veteran-specific therapy competency, it's no longer the number 1, 2, or 3, priority in the field. This is my opinion, of course. I don't have a statistic to back that up. But I'm concerned about some of about the thing that you just raised. Like, how do we make sure that a veteran walking into a community mental health center gets the treatment and doesn't walk out saying that they don't know what they're doing, right? I'm really concerned about that.
Right, and that's exactly, and some of the reason why I'm trying to do this and obviously bring mental health providers to the veterans and normalize sort of that experience. But it's something that I always say, if a veteran is going to knock on the door, and that's what we're trying to do now. We're trying to say, reach out for help. If you're suicidal, reach out for help. If you're, if you're in crisis, we're trying to, and of course it's not happening either on a general mental health level or even specifically veteran mental, but we're doing our best to try to make that more normalized and say, yes, veteran, if you're in crisis, reach out for help. Then when that veteran reaches out for help and they don't receive the help that they were quote unquote promised, then they're just, well, I'm not even back at square one. I'm 3 feet back from square one, and screw it, and I'm just not going to bother.
Because you might have lost a little faith at that point, right?
Or a lot, verify the fact that, well, I knew it wasn't going to work, and you just confirmed it and just solidified my belief. So there's danger there.
I think that's where we are in the field as mental health professionals, and it's a real barrier. And talking about suicide for a second, there's great suicide prevention awareness. We're doing better than ever about awareness campaigns. Just about everybody knows 1-800-273-8255 and press 1 if you're a veteran. Just about everybody. They've done a great job. And I know a lot of those folks, and I work with those folks, and I'm proud of those folks. And but the next piece is, how do the evidence-based treatments get implemented and disseminated. And that's the concern. The VA is doing really well. Before we even say the myth, let's clear it up. The VA, people that get treatment at the VA are getting better treatment than just about anywhere else. And that's statistically proven, right? We have the research that shows that. That doesn't mean that everybody's going to the VA. It doesn't mean that everybody can get to the VA. It doesn't mean everybody wants to go to the VA, right? So the people that use the VA are by and large getting outstanding care by mental health providers. And it's not nearly enough because there are more providers who aren't in that system that are getting the training of the evidence-based treatment for suicide, preventing suicide. And we have it. We know how to treat it. So we're doing a good job with making sure people know who to call to get for help. But if they get a referral, does the referral know what to do? And now we're talking about money, right?
Right.
Because it costs money and it costs time and it costs training and it costs commitment of organizations to train their people. Now the VA is doing that, but what about the outpatient staff at a hospital that isn't a VA? Right? What about community mental health centers? What about private practitioners? So this is the challenge of the profession right now. We know how to treat PTSD and suicide. We absolutely do, with good results. Finding the right provider isn't so easy. It should be easier.
Right, and so even on that with the suicide thing, and everybody says we need to solve the suicide problem, but the veteran suicide epidemic is just indicative of the deeper problem. You know, suicide is, and not to trivialize it in very much, but it's a symptom. It is a lagging indicator of whatever that veteran is experiencing, and so. And again, not to trivialize it, but I often describe it as if I go into the doctor with a runny nose, the doctor needs to understand whether that's allergies or whether that's the flu, because they treat those two things differently. Now, if if a veteran comes in with suicidal ideation, is it because of substance use and their family life is wrecked, or is it because of PTSD? Because I'm going to address each of those differently. Or is it because of their guilt and moral injury? Or is it because they simply have no purpose and meaning? They've never experienced trauma, but they're so, engrossed in their lack of purpose and meaning that suicide is there. So the correlation, the one-to-one correlation that suicide must mean the veteran has PTSD, that's just as false an assumption as all combat veterans have PTSD. Yeah. And so trying to explain that kind of nuance and even the ability to assess the difference between the two, that's what you're talking about.
Yeah. I mean, there's a lot in here. The truth of the matter is we've only known how to treat PTSD effectively, like really effectively. We've only known how to treat it for 25 years, right? And it's really only in the last 10 or 10 to 15 that news is even out there, right? And we're still in the stage of trying to get all the providers to learn how to do this. And think of it, there's plenty of people that have been in the mental health field for 15, 20, 30 years. So if their training was a long time ago and they didn't get additional training with the new techniques to treat PTSD, they're using really good general therapy techniques to treat PTSD. They're really good therapists, but they're not treating the condition as well as we know how to treat it now, right? So it's actually a real problem in the profession. How do we get somebody that's been in the profession for 15, 20, 30 years, how do we get them to do a new technique, right? How do we teach an old dog to do a new trick, right? I don't say that judgmentally. It's hard to talk about this without it being judgmental against somebody that's been doing this for 30 years. Somebody who's been doing this for 30 years is really good.
Right.
but we know more now than we knew before. We know, and so if effective PTSD treatment is about 20, 25 years old, effective suicide treatment is younger than that. Effective suicide treatment it's essentially started with DBT, and it's gotten better since then, right? So that's early 90s, and then it's gotten better since then. It's gotten really, really good in the last 5 years. The last 5 years is really recent, right? To get that out into the field is a huge challenge, right? We're all struggling with that right now. So, am I going to treat depression? Am I going to treat suicide? Am I going to treat PTSD? It all looks a little bit different, and that's the challenge, right? And reintegration, right? It could be none of that. It could just be, how do I reestablish, what skills are useful, and how do I turn off the ones that are no longer apply, and how do I keep the ones that do, right? That's not necessarily somebody having PTSD. So that's, I think, what some of the profession is struggling with right now.
No, I really appreciate that you brought that out. I mean, that's huge. And again, that it's so nuanced, and we do have to be kind of constantly evolving and constantly more. It's because the situation is evolving. The veterans that you worked with in 2005, they were separated by their military experience by decades in many instances, whereas veterans that I'm seeing now, it's been months or it's been years. It's almost like it's been accelerated and it's been exacerbated. Personally, for me, I didn't have 1 year between 2006 and 2013 that I wasn't separated from my family, whether it was training or deployment. So that was a huge chunk of time where either the entire year or portions of the year that I was gone. And so that lays a layer of complexity on top of what they commonly knew. And then you have the emerging constructs of moral injury being a component of or even separate from post-traumatic stress disorder. Yeah, Jonathan Shea was talking about it, and he saw it in the 80s, but it's really, again, only emerged deeper and more prevalent within the last 5 to 10 years, like you said. And that's, again, different techniques to address that. Prolonged exposure absolutely works great if we're dealing with post-traumatic stress disorder. Existential psychotherapy works for a lack of purpose and meaning, and how do I make meaning of the loss of my friend and things like that. Prolonged exposure doesn't really apply to survivor's guilt necessarily, and so it's really trying to make that kind of distinction.
And you know what, you just brought up another side of the coin, which I've been really fortunate. I had psychodynamic and relational interpersonal training before I ever got into working with military and veterans. And some of the existential and psychodynamic therapies that you're talking about, they're so very different. And I still come from that place. When I got into working with military and veterans and doing prolonged exposure, I'm a prolonged exposure therapist, and treating suicidal behavior. These are behavioral or cognitive behavioral, like purely behavioral or purely cognitive behavioral techniques. I'm really grateful for my experience that I've been able to work through each of those paradigms, because it's a real gear shift as a therapist. To say, I am going to work as a prolonged exposure therapist, which is a behavioral paradigm. But if we're talking about moral injury, and I'm going to get back into my psychodynamic training, which is where I formulate, some of that stuff. When do I not be a behavioral psychologist, right? There are a lot of different factions in our profession, and the factions in our profession that are focused on research and PTSD and suicide, they're in the cognitive behavioral camp, right?
Yep.
And psychodynamic and relational and existential therapists, I'm really generalizing. I'm going to make some people mad here. psychodynamic and folks don't trust behavioral evidence-based approaches. Evidence-based and evidence-based and behavioral approaches will say, but we do value you, but these are the constructs that work. And so you have to do it this way. And everybody's talking past each other. And the ability to shift gears, I still value it. I absolutely value it. And if I'm working with somebody in a prolonged exposure, I am on protocol. I am on session 6, and we're starting with a check-in on the homework and blah, 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 right? I am doing that stuff. And you know what? If we do that work and we get past it, and then we transition into moral injury and existential stuff, and we're going to get into psychodynamic constructs, I am in. Like, I love that work and I believe in it. It's very hard to codify. It's very hard to talk about the evidence base of that. It's so dramatically different. I value both. But that's how many people we have in our field of psychology and social work and counseling. There's so many different approaches. Like, I don't always believe in solution-focused therapy. I don't, right? Sometimes I say, yeah, you should feel like shit, right? I say that all the time, right? You know, and I don't always believe that I have a cognitive behavioral solution that somebody is going to leave with something to practice that's going to make their life better. At the same time, if we're talking about suicide or PTSD, you better believe I'm going to do it because I know it works. It does work. And if I don't do that stuff, I wonder if I'm practicing ethically. That's how I think about it, right? But the moral injury, I don't know that we've codified that yet. So I better have some tools outside of cognitive behavioral interventions where you're going to, track a thing and tell me if you've improved your moral injury over the next week. I think it takes a little bit longer than that. So and that's a tough thing to talk about because there's so many in our profession that really believe in one approach or the other approach.
Right. And typically and again, I work exclusively with veterans and military spouses. I've not, I shy away from teens, so I'm right. and I'm very much focused on, but for someone who has post-traumatic stress disorder from a vehicle accident, for example, that the moral components and the questioning components and the existential components aren't there, right? Or not there as prominently. And so perhaps with certain clients, if we're dealing with major depressive disorder or children of abuse, for veterans, it's much more complex trauma and complex situations that this client group or veterans require an integrated approach because their needs are integrated with each other.
I don't disagree with that, but I also wouldn't want to make that an absolute, right? That I would say in my experience as a prolonged exposure therapist, I think we can get there within the protocol. I think we can absolutely get to the place where we're talking about guilt and shame. And we're talking about not just guilt and shame as words, like deep guilt and shame and self-doubt and moral injury. I think we can get there within the protocol. Like I would be, so when I say, and there are sometimes when we can't get there within the protocol and we got to clean up some symptoms and we've got to get some symptoms out of the way in order to get to moral injury another way. But just as often, maybe even more than not, in my experience, I can only speak to my experience here, I think that we can get there within the protocol because those themes are, I think that those themes are there. And, if we're talking, I'll get into the weeds of prolonged exposure just very briefly. We can do another podcast on what it is.
Just, on that altogether, right.
On that altogether, we certainly can. Which would be fun. When somebody's hearing their story again and again from their own voice, from their own experience, and they hear it change over time, and then they hear themselves challenge it in a processing if you don't know what prolonged exposure is, what I'm talking about now, if a listener doesn't know, this may not make much sense to them, but which is fine. But they start to say, it doesn't make sense that I think of it that way.
Mm-hmm.
Like,
right.
It wasn't me that did this. Like, I thought this was my fault the whole time. I thought that this was something that I should have prevented this whole time, but I couldn't have prevented this. Now, you can't just hear me say that and have that be true.
Right.
But the process of prolonged exposure therapy gets there really powerfully. Not 100% of the time, because it's not 100%. But wow, can it happen in a profound manner? So I think you can get to moral injury sometimes through prolonged exposure therapy and through CPT, cognitive processing therapy. But I fully endorse what you're talking about. Sometimes it calls for a different approach to get there.
And again, and like you said, and as you've obviously gotten to that, is the awareness of when to shift gears. And that, I think, from this conversation that I'm getting, is there's a need for mental health providers to understand when to make that shift. And also there's a need for veterans to step into that gap to be able to take the chance, because like you said, life sucks and it feels really crappy right now. Yeah. And I can walk away and still continue to feel like crap, or I can work through this and have this person who has the skills be able to help me through that.
100%, right. I'm saying again and again, you're hearing me say, PTSD and suicide are treatable. And not only that, the treatments are effective. You've never heard me say they were easy, right? I mean, right. It's the hardest work somebody's going to do. But that said, I can confidently say if we do the work and we do the work the way we're supposed to, I'm really confident we're going to get somewhere, and not just get somewhere, but get somewhere soon. Right now, that's hard work, and it's not going to be easy, and I'm going to challenge somebody. That said, if we know what's coming, because we do know what's coming in these treatments, we can prepare for them, right?
Right. Mm-hmm.
And you know what? Guess what? Anybody who's gone through a trauma that's walked into my office, like let's bust another myth. I don't want to do it. I can't do it. I don't want to talk about it. I can't go back there. You know what? Nothing's going to happen in my office that's worse than what happened.
Exactly.
It's just, and so it's a myth, not just within the mental health profession, but for people with PTSD and our culture. We don't want to re-traumatize somebody. Nobody's getting re-traumatized by this work.
Right.
It doesn't work that way. Now, it may feel traumatic, but guess what? You're still in my office on the couch. The door is closed. It's still you and me. We're still doing our thing. That in and of itself is not traumatic, right? Now, some of the work is how to get there and how to talk about that so that that's a learning process. So somebody says, oh, you know what? It didn't happen again. I'm not re-traumatized. But there's not this re-traumatizing experience. There's, oh, now I can talk about it and learn something and do something differently. And there's a process to that. But that's a fundamental thing. So re-traumatization is I think we really need some myth breaking about that one. It just doesn't happen. At least...
No, absolutely. And I think that we as a profession, as mental health providers, aren't talking about that enough. We're not communicating in this way. A lot of people are talking about veteran mental health, but very few of them are mental health professionals speaking directly to veterans like you're doing here, on this podcast, or like you're speaking directly to providers who are working directly with veterans. We kind of maybe talk amongst ourselves, but we got to get the message down. Yeah. And you said that, yes, it's not easy. It's not going to be easy. It wasn't easy that you went through it in the first place, and revisiting isn't going to be easy. But I want to, reiterate the point that you made, that it's not going to be forever. Right. This isn't Freudian psychoanalysis. We're going to be doing this for the next 2.5 years. That's right. So yes, it's hard, and yes, it even say it's going to suck. but how much does your life suck now when you don't go through it, right?
Right.
If you don't approach that pit and get through the pit or get through the ravine or get through whatever the metaphor you want to use, get through that dark valley, you're going to be stuck on this, functional, variably functional, but you're just not going to feel as well as you do, as we know you can on the other side.
Yeah. I mean, the truth is, it's not just hard. I mean, trauma is horrific, right? Somebody that's experienced that trauma, whether it's combat trauma or sexual assaults or a car accident, right? It can be. The despair that somebody feels from having experienced that horror is so deep in their lives. Somebody's in such pain, right? So I really need to be able to reflect that back as a therapist. Like, I get how deep that is. I really do. I don't want you to walk around with that despair for 1 minute longer than you have to. In order to get to the place where you don't have to walk around with that fear, we got to go through some really hard stuff, right? But in the context of, we know how to do this. We know what it is. Yeah, it's hard, but it's going to go somewhere, and you won't have to have this, right? That's a real message that we should be sending. It's a much different message than Vietnam veterans ever had. Mm-hmm. It's a different message than pop culture understands. You got PTSD, you're going to be there forever, you're out of control, you're violent, all of that. That's all, none of that's true, right? The truth of PTSD is it's a despairing condition that destroys somebody's life, that makes somebody go, I don't know what to do. Well, guess what? We can help that. We know how. There's good news there. It's not fun. It's not easy, but it's simple, and I know how to do it, and I can help you with that. Let's do this. I'll walk through it with you. And on the other side of this is a different life. It's a life that you're not living right now. You get to live the life you want to live. That's where we need to go with this.
And I think the big thing there, Ted, is you as a provider, trust that you've been there, you've seen the other fields, you've seen that, what happens after. But then the veteran has to trust you as a competent professional that's able to help them through this. And that goes back to our earlier discussion of, if the veteran even gets one whiff, it smells fear, whatever it is, if they even get one sense that you're trying to be disingenuous, that you're trying that somebody says, oh, I understand it, you're broken, I can fix you, just one instance of that can set a veteran back years.
I totally agree. Another myth. I mean, we could do a podcast on myth busting. And this is a mental health professional challenge, right? Like, I don't know if my client can handle it. I don't know. It's pretty early to ask him or her to do this thing. You know what? The people, in my experience, the people that are walking around with PTSD that have experienced something, what can I do to that person that's going to hurt them? These are the strongest people I've ever met. Now, they don't feel that way. They feel weak, right? Part of the condition is I feel weak and I can't handle it. But my experience from the outside is this person I can't even imagine this person walking around with this memory replaying again and again. Think of the strength it takes to walk through life with that experience never leaving them. It takes such incredible strength to survive the day. I'm asking you to tell a story. I'm asking you to tell the story. Now I'm going to ask you to tell it again. I'm going to ask you to tell it again. That's prolonged exposure. There's other methods.
Yeah.
But what am I going to? How is that going to break the person? They're thinking about it already, right? They're already living with that experience and that memory again and again and again and again. I'm going to help them break that cycle. But there's nothing that I'm going to have that person think or feel that they're not already thinking and feeling and conquering on a daily basis. 5 weeks into treatment, you start to see people shift. You start to see people dress differently and carry themselves differently and talk differently. And it's like 5 weeks, you're starting to see a change? With PTSD? Well, yeah, right? That's how it works.
Right.
So I don't want to treat someone as fragile. I don't want to send a message that you can't handle it and I'm worried about you. Baloney. You can do this. It's gonna be hard. I get it. I hear that concern. Makes sense. Makes sense you'd be worried about that. Well, let's talk about that for a little bit, right? We mental health professionals, we gotta have some confidence in this, that it works, and there's nothing I can do. There's nothing I'm gonna do within the ethical bounds of my profession, right? There's nothing I'm gonna do that is gonna be nearly remotely as like, let's use combat trauma. What's gonna happen in my office that's gonna re-traumatize combat trauma? It's just not gonna happen, right? So I think that that's on us. We got to carry that, right? We mental health professionals, we got to carry that.
Absolutely, and a lot of it, again, that's why we're trying to do this, trying to get this message out there through this podcast, through the blogs, through social media, that we, as a profession, need to be able to signal to the veterans that need our service that we've got this, that there is going to be somebody that can answer the door when you knock.
Yep, absolutely.
This has been a great conversation, Ted. I really appreciate it. Any last thoughts? Any final words?
I appreciate this platform, and Dwayne, I really got to say, I've been I so enjoy your writing and your podcast and your message. I think it's an angle we need more of, right? Veterans talking to veterans about mental health, about what does a veteran need to know about going in to see a mental health professional. It's so helpful. It's so needed. So I'm just I'm appreciative of your efforts in this platform, and thank you for having me on.
Well, absolutely, and in the same way, I'm appreciative of you and other providers. I say it often that you don't have to be a veteran to treat veterans. My clinical supervisor now, amazing. She works with sex offenders, so I mean, she is an amazing clinician, and she's not a military service member. And so she, like you and many of our other colleagues, have taken the time to learn to understand the culture and are as culturally competent. Yes, I'm a native speaker of acronym. You've had to learn the language of acronym, but you and I could probably have a perfectly good conversation in that language. And so I'm appreciative of you and being able to come on here and show veterans that, okay, yeah, he's not a vet, but I could sit there and I can talk to him because they can answer my needs. So thank you for coming on the show.
Thank you.
You're listening to Headspace and Timing on the Change Your POV podcast network. So there you have it. I really enjoyed how Ted identified the need for mental health professionals to take the time to learn and understand veteran culture, but also the need for veterans to trust mental health professionals. Treatment works. I know it, Ted knows it, and it's been proven time and time again. You want to make sure the clinician you're going to see is going to understand your unique situation, but overall, you want to go somewhere that can help. Thanks again for taking the time to listen to the show. Now that you're here, make sure that you stick around by subscribing to your podcast player of choice. If you're not sure how to do it, drop me a line at Dwayne@veteranmentalhealth.com. Make sure you spell it the right way, D-U-A-N-E. You can find the show notes for this episode and all the episodes by going to veteranmentalhealth.com or changeyourpov.com. Sign up for updates on either or both so you don't miss another episode. While you're at it, check out the other great shows in the Change Your POV podcast network. Changing Hearts and Minds with my buddy, Special Forces Weapons Sergeant Jeff Adamek. A show about outdoor adventures that us veterans love so much, Neophyte in the Woods with Andrew McDowell. And of course, our flagship show, hosted by Eddie Lazary and Bennett Tanton. Stick around next week when I talk to another veteran and mental health professional, Reg McCutcheon, and the work that he's doing in Georgia regarding veteran mental health. Or a couple days after this, Andrew McDowell and Jeff Adamek are going to be talking about the greatest battle implement ever invented on episode 18 of the Neophyte in the Woods podcast. Is it the P38? Could it possibly be the Headspace and Timing gauge? Guess you'll have to tune in to find out. If you're looking for the total package for all the information you need to live the life you want after leaving the military, you found it. I want to thank Doc Todd for his permission to use his track Not Alone from his amazing album Combat Medicine. Doc Todd's somebody who's trying to bring veteran mental health out of the darkness and into the light, and you can get the album by going to www.therealdoctodd.com. Check it out, because remember, veterans, you're not alone. Ever.
The struggle is real, found a feast and lost a soul. Eventually my drinking, it got out of control. There in darkness I roam, struggling to find home. See, suddenly death didn't feel so alone. 22 a day, destination unknown. It could have been avoided if you picked up the phone, but now you're gone, so I guess all we get is the tone. Nothing but bone weeds, overgrown, pushing up stones. I've triumphed over enemies, co-created enemies. Broke out facilities that tried to put an end to me. R.I.P. I'd rather grind in tranquility. Authentic tendency, embrace my ability. Gave every shred, every last thread of my identity. Conquer my fragility, eliminate the enemy. Deliver me, God, from temptation. Tell me that this life is just a matrix. Need a facelift, back to basics. Vision LASIX, I only feel alive when I hear the bass kick.
Oh, I try so hard to have faith. I bow my head and I pray. Lord, please lend me the strength to carry on and keep standing.
Stand up.
How this life so demanding. So much pain on this planet. I hurt each time I wake, but with you I'm not alone.
Not alone. Yeah. You're not alone.
Oh yeah. And every time that I fall, I'ma call on you, pick myself back up again.
Yeah, just pick up the phone, you're not alone. Just pick up the phone, you're not alone, man. Just pick up the phone, you're not alone. Yeah, pick up the phone, I'm right here. And I love you guys. Take those bottles out, dog, and pour them in the sink. Take the needles out your arm and the gun away from your forehead. It's time, man, you've been through enough pain, stand up. It's time to stand back up. All my veterans, man, Army, Marine Corps, Navy, Air Force, Coast Guard. Get up, you know.